Welcome all delegates to the APHRS Asia IPAC 2022 SVT module, Frontiers in SVT Management. The session starts off with Dr. Balbir Singh, who would give us a welcome address, a recap of session 5, and an introduction to session 6. Over to you, Dr. Balbir.
Yeah, good morning, everybody. And we are in for the 6th session. And this is the penultimate session for this whole SVT module. So we started with Sam having an anatomy, EP correlates, contrapositions, importance of anatomy. Going on to Hiroshi discussing about parahesian pacing and Narasimhan talking about the SVT maneuvers. We went to a beautiful talk on AVNRTs with Nitish Badwar and followed by some live in-box cases, 3 of them actually. We had AVNRT ablation, fluoroless AVNRT ablation, followed by an it was again on 3D without fluoro, and then we followed it up with an atrial tachycardia. So 3 live in-box cases. We had accessory pathway ablations discussed by John Roshan and Namudri. And after SVT maneuvers, accessory pathway, AVNRT, we move on to a very important session today. We actually discussed briefly about fluoroless SVT ablation, but as we go in time further, we know that fluoro exposure has become a most important aspect for SVT ablations and AF ablations. And in our lab now, the AF ablation dose, radiation dose, is 1/3 or 1/4 of what an angiogram takes. So it is just conditioning yourself. And we don't have any better person than Professor Ching to tell us about fluoro exposure in the lab during SVT ablation, the transseptal approach. Professor Ching is from Singapore, is a very renowned electrophysiologist. He's an editorial position in many journals, including Journal of Arrhythmias and Singapore Medical Journal. He's done pioneering research in CRTD versus ICD as primary prevention. So he's presently the course co-director of APHRS, and it's a great pleasure to have him here because we worked together to make these 4 sessions, and it was a great interacting with him, and we understand how in-depth understanding he has of teaching and research. So it's a great honor to have Professor Ching with us. And similarly, Dr. Yash. Yash is a wonderful person, a great electrophysiologist, a very keen research worker, so many beautiful international papers, some of which on SVT maneuvers are so good that one keeps reading them and really enjoying it. It's a great friend and is in Mumbai, mainly working through Holy Family Hospital. And it's a great honor to have Yash, who is presently the president of IHRS. And as usual, we have Narasimhan, my friend, and we have worked together several times. And this course is a remarkable example of 3 of us getting together, Professor Ching, Narasimhan and me, and trying to bring out a beautiful course. And as I said, from these previous sessions, I can tell that I'm sure everybody learned, but I can say for myself that I learned a lot of new things in this symposium. So we will move on to our program for the day. And I request Professor Ching to take over how to do low fluoro ablation. So I would not say zero fluoro ablation, I would say low fluoro ablation. Sometimes zero fluoro can add to complications. So you are not so rigid that I don't want any fluoro. Fluoro reduction is the key. Over to you, Professor Ching.
Thank you, Dr. Singh. Send greetings from Singapore. It's indeed a pleasure to work with such a dedicated group of professionals who wants to impart skills and knowledge to the folks who treat patients with heart rhythm abnormality. Yeah, I need to share my screen. If you allow me to share, that's great. Thank you. All right. So my task is to talk on fluoroscopic reduction, 3D SVT ablation, and transseptal punctures. Rightfully said, we do not strongly advocate or mandate zero fluoro because one may get into problems, and a skilled operator would utilize or exploit all technology to make the procedure safe, efficient, and hopefully quickly or in a shortest possible manner. Right, these are my disclosures. Now, first we have to ask ourselves, what is the impact of 3D SVT? A typical SVT ablation comprises of the few steps as illustrated. You need to have successful venous access safely, and in our lab we do it with ultrasound guidance these days. Secondly, you need to place the catheters at various chambers so as to do your third part of the procedure, which is to do a robust and vigorous EP study. Then you decide where are the targets for ablation. You may then have to decide whether you need to go transeptal or retrograde aortic approaches for some of the left-sided accessory pathways involved in SVT, or a left atrial tachycardia. Now, the impact of 3D SVT ablation will only impact these few steps. Catheter placement, because you may place them without or little use of fluoroscopy, and ablation. It has no impact on how quickly you get venous access or arterial access. No impact on EP study. May not adequately influence transeptal or retrograde aortic approaches, because you may need fluoroscopy for safety measures. Let me share with you my center's approach. I come from Singapore, and we managed to publish this to share experiences in non-fluoroscopic navigation system to guide RF ablation. Well, we look at mainly patients with SVT, and on this chart, we recruited about 80 patients in the non or low fluoroscopic arm versus conventional fluoroscopy with 121 patients. These are some of the demographics. I just want to point out to you that just about 35 underwent AVNRT treatment with non-fluoroscopic approaches versus 66. For the AVRT, there were right-sided accessory pathways in 19 or 25% of the patient, and 17 in the conventional arm. 25 patients had a left-sided accessory pathway compared to 38 patients with a left-sided accessory pathways undergoing conventional approach. Let me share with you. Well, to get yourself ready for low fluoro or no fluoro SVT, after you gain access to the veins or artery, you will have to, of course, set up your system. The NAVX patches, for example, needs to be on the patient. The catheters should be connected to the system, to the ESI system, and it can be visualized. And once the catheters are in the intravascular space, all right, we, as with normal practice, put in a decapolar catheter. In this case, it's a live wire decapolar catheter. You can see the green color tells you that's the tip, distal electrodes, whereas the truncated refers to the proximal end, which is the 10th pole of the electrodes. You see that the whole catheter with its 10 poles are shown in a straight line, telling you that it's straight. And as you advance into the IVC, pay attention to the electrograms recorded over here on my cursor. Right, 7-8 refers to proximal, 1-2 refers to distal. As you can see, once it goes near or into the chamber of the right atrium, you will see EGMs on the distal poles, distal 1, 2, 3, 4, telling you that this part of the catheters has arrived at the right atrium. You may then advance slowly, carefully, cautiously, high up. There's some atrioectopic as seen, followed by, let me just play that again, some atrioectopic as seen, and then followed by absence of electrograms on the distal. As you can see, it goes up, the electrograms on the distal poles appears. As it goes further up into the high right atrium, there is atrioectopy as seen, conducted in an aberrant manner, and some perhaps atrial echoes or AVN echoes. Well, it's too early to gauge. And as it enters into the SVC, you will see then that the distal electrodes begin to have their electrograms amplitude diminish, telling you that you are into the SVC. So this is one way to place the catheter from IVC to RA. Next, after you have done that, we normally would curve the catheter as you would. Now let me just orientate you. This is the RAO view as shown on this icon, torso, and this is the LAO view. And as you curve the catheter, as shown previously, and the catheter enters into the coronary sinus. Let me show you once again. You curve it down, and as you clock the catheter posteriorly, you see the typical curve of the CS or decapolar catheter reaching for and entering the coronary sinus on the RAO view and on the LAO. And you will be able to see the electrograms appearing bit by bit, typical of a CS electrogram as you enter the coronary sinus, as you could see in this video. So that's how we place within a catheter into a coronary sinus. Likewise, you have the same maneuver, putting the catheter. We normally use a CRD2 or just a decapolar or quadpolar, a fixed curve quadpolar catheter. As it advances, as you can see, this advance across in the RAO, it crosses the tricuspid annulus. This is the LAO view. You will look at the electrogram, largely in the A, in the right atrium. As you cross the annulus, you begin to see on the green colored catheters signals depicting the His. You will see that on the right, last electrogram, last QRS, you can make out a His electrogram on the catheter. Let me play that. So it enters, you get PVC and nectar P, you draw it back, and then to a position that you are satisfied with, and you could record the His signal accordingly, or in the RV accordingly. Next would be a catheter in the His. If you want to put one as a reference, it's a CRD2 in the same manner, same maneuver, and you will begin to appreciate that once it's at the His region, the His signals appear as you would on a regular catheter placed via fluoroscopy. You would see on the last complex the A, the H, and the V signal. And at steady state, this is how a catheter looks like on fluoroscopy. This is its corresponding X-ray or fluoroscopy images of these catheters. You see that it corresponds very well to what you see on the X-rays, right? In RAO, this and RAO on the fluoro versus LAO. We normally would put, once we identify the His region, we would tag it. In my lab, we tag it in yellow color as a His cloud. You could even map the His from the ventricular end near the right bundle branch potential all the way backwards to the atrial end of the His electrogram. Hence, this gives you an area of no-go zone when you do an ablation. Right, so in AVNRT cases, if that turns out to be AVNRT, we will then use the 3D maps to guide placement of the ablation catheter near the slow AV nodal pathway. This is a typical area. The electrogram shows features suggestive and consistent with a slow AV nodal pathway. It is anterior to the CS, os, near the roof. It is septal, below the His bundle cloud, and we ablate. And if it's successful, as you would see that in this case, there are junctional rhythm upon application of RF energy. We put a tag to mark out site of successful ablation spot, and we can go back to give additional ablation as needed without fluoroscopy. Of course, please use fluoroscopy as needed in a safe manner. So in our experience with AVNRT, this is in 2016, 6 years ago, right, in the pilot study, fluoroscopic time was utilized significantly lower in the non-fluoroscopic arm versus conventional arm, just under 7 minutes versus 20 minutes. And previously, I was taught, and to step on the fluoro each time you ablate, deliver RF at a slow AV nodal pathway. For conventional arm, we are very worried that the catheter slips upwards near the His and cause inadvertent AV block. The radiation doses, as expected, is significantly lower than that of the conventional arm. There is no impact to procedural time. Remember, the impact of 3D SVT is really in placement of catheter and in ablation. Those two may not differ much compared to the conventional arm. This is an example of right prosteroceptal accessory pathways. On the lower EGM, on the lowest part of this slide shows the EGM, surface ECG, CS signals, as well as the EGMs. It is a manifest right prosteroceptal WPW. Likewise, this is the catheter in the CS in the RAO view, corresponding LAO view. This is a CRD placed near the HIS and advanced to the RV septum, and this is the ablation catheter. Now, likewise, there's a HIS cloud to denote where are the dangerous spots, where the no-go zone for RF delivery. And as we map and ascertain this to be the earliest site of ventricular activation with potential accessory pathway signals, you see that as we apply energy, RF energy, after 3 beats, there is loss of pre-excitation with corresponding PR interval as seen over here. And you could tag green being areas of successful ablation. And we know that post-pathway ablation, if it's guided by fluoroscopy, the position is at most an estimate. It is influenced by breathing patterns of the patient. The fluoroscopy does not give you a good definition or resolution as to where the exact spot was. However, 3D is able to fine-tune that. Spot is given, a shadow of the CS is usually taken to denote that the live catheter that moves is aligned with the shadow, and hence the geometry is reliable. We will go back to the same spot to deliver RF ablation. Right. This is an example of what it looks like for a right lateral pathway ablation. On the left is the fluoroscopic picture. It looks similar as it would on the right, which is the 3D anatomy of a right lateral accessory pathway. In our experience, we find that the fluoroscopic timing is definitely shorter in the non-fluoroscopic arm versus the conventional arm. It's much higher for right-sided because of the instability due to the vertical nature of the tricuspid annulus. So it's significantly lower in terms of fluoroscopic time. Radiation dose is definitely lower for that patient. Procedural times remains similar for a right-sided accessory pathway. Now, what about left-sided accessory pathway? If you do a transeptal, please use fluoroscopy as needed to make the procedure safe. If you do it via retrograde aortic, you could do with fluoro or minimally relying on fluoroscopy and make use of 3D. So this is a video of a catheter in the aorta. It has crossed the arch, all right? And as it crosses the arch, you see that the catheter, right, is curls on itself. This is the distal tip. This is the proximal shaft of it. These are the electrodes 1, 2, 3, 4. Right, so you can see that. Imagine the shaft, and it curves as it crosses the arch of the aorta, going down the ascending aorta. This is a person with manifest left-sided accessory pathway. All right, so as it crosses, in this case, it crosses the aortic valve and slips into the left ventricle, as you would anticipate with conventional approaches. You could imagine how the catheter moves as well. So it is a good guide in place of fluoroscopy. And show you an example of a patient with AVRT involving a concealed left lateral accessory pathway. This is on the lower slide. You see there's onset of tachycardia. The distal CS here, 1, 2, proximal CS being 7, 8, and 9, 10. This is a narrow complex tachycardia, and the atrial activation is eccentric, earliest right along the distal CS, and we could then map with the ablation catheter. Now, and on site, right, you can see here map during V pacing with eccentric VA conduction. And on site, where you determine it to have the shortest VA, or even accessory or pathway potential, you deliver an ablation burn, and there is loss of VA conduction. You could then tag and further deliver adjuvant ablation for this patient. And this is the X-ray pictures versus X-ray versus 3D on the other side. You could see that it looks similar, be it fluoroscopic or be it 3D images. And our experience shows that the fluoroscopic time is also significantly reduced in the low fluoro arm versus conventional fluoro arm. And the radiation dose are as such. And the procedure time is no difference. In fact, in this case, it seems longer with the conventional arm because perhaps to deliver additional ablation using fluoroscopy is very gross, and that may reduce or prolong the procedural time. So, ladies and gentlemen, placement of conventional catheters can be done with limited or no fluoroscopy. There is significant reduction in ionizing radiation without prolonging procedural time or impact to success rate. Now, there is a learning curve, of course. All this near zero fluoroscopic technique has been reported, right? You could avoid fluoroscopy entirely. You could limit the use of fluoroscopy. All procedures were acutely successful, all right, with little or no impact on procedural time, great impact on radiation time or fluoroscopic time. And it is feasible, safe, and effective. The learning curve exists, or suggests that in those who published, the early era being defined as the first 12 months of the procedure versus the recent era, all right, acute success was achieved in the early era compared to 97% in the recent era. There is no significant complication, and procedural time, as expected, would reduce as we are familiar with the system and approach. And recurrence rate, as you could see, were lower in the recent era. Clearly, function, the procedural time signifies a function of experience. We advocate low fluoro, not zero fluoro, because complications such as this may occur if we were to advance, and there is resistance. Without knowing that, you advance the loop further, and when you retract the catheter, you may form a knot, and the knot becomes tightened when you try to withdraw the catheter over the sheath, and you have this complication of a knotted catheter. This was unknotted successfully, and the procedure carried out with no further complication. So we do not advocate zero fluoro. We advocate reduction in fluoro, and as much as you can in a safe and feasible manner. Well, the next topic talks about reducing fluoro in transeptal punctures. I like to advocate the use of intracardiac echogram in transeptal punctures. This is a typical phase array of a ICE catheter. It uses piezoelectric crystals on this site, all right, and provides spatial and temporal resolution of the images. It provides image depth. It shows the immediate chamber and the chamber next to it fairly clearly, and that can be used for various purposes. Guidance of transeptal puncture, assessing tissue catheter interface in the left atrium, looking for complications related to SVT, AFib ablation, or even VT ablation. Let me show you some examples of how we may utilize ICE catheters in transeptal punctures. So this is the typical maneuver of putting a SL0 sheath over a wire to prepare for transeptal puncture. Now this catheter on the right, as it loops over here, is the ICE catheter with a phase array facing the left atrium, and this is a catheter within the coronary sinus. So simultaneously, right, as you withdraw the catheter, right, to engage the interatrial septum around the fossa ovalis area, or you will be able to see on ICE placed in this manner. You may have to clock it or turn it to show the interatrial septum as seen on this picture. This being the left atrium, right? You would be able to make out the os of the left inferior pulmonary vein over here and the LSPV over here. And you would visualize that the interatrial septum is well tented by the transeptal apparatus. As you inject some contrast or flush the apparatus, you may see irrigated saline across the interatrial septum as it tends it. So you know that, hey, you're in a safe spot. Of course, I would additionally confirm the position on RAO, LAO before I puncture the interatrial septum. Now for AFib ablation, where this is one where we are confident, you puncture and I will then give some contrast to ensure that it's in the left atrium and the sheath is advanced into the left atrium as seen over here. Now, very often you may want to puncture the septum a second time for AFib work. And this is one example. The first transeptal puncture has been achieved and there is a lasso, a circular mapping catheter in the left atrium. The second puncture is done. It's just a little lower than the first. It tends the interatrial septum very well. You could see in the far field or in the further away from the transducer, the LSPV and the LIPV. And in this case, we're able to capture the transeptal apparatus sliding across the interatrial septum, achieving safe and expeditious or quick transeptal access to the left atrium. It is very useful in difficult cases. You know, Dr. Babu Singh, Dr. Yash, they're all very experienced folks. They don't really need this for their transeptal access. But as we establish our practice, or in difficult cases, it is extremely useful. This is one example. A patient with rheumatic heart disease coming in with atypical atrial flutter. You can see that the right atrium is grossly enlarged. The catheter has to be placed in the coronary sinus in this loop, so that it can engage the coronary sinus. This is the annuloplasty ring on the mitral, on the tricuspid side, right? And we try to do a transeptal puncture. Now, where is a good spot to puncture? It is so huge, distorted, and I will show you on the ice. You can see it too, that it is a very difficult and a challenging transeptal to be done fluoroscopically, because we don't really know whether we are tenting or touching the interatrial septum. And I really have to curve the transeptal needle to beyond a BRK. It's like a wide curve, like almost a Mullen sheath-like curvature of the transeptal needle, so as to achieve tenting of the interatrial septum along here. And this patient also has spontaneous echo contrast, and hence it is of paramount importance to anticoagulate the patient adequately before even doing a transeptal puncture. And as a routine, I anticoagulate my patients with heparin boluses before doing a transeptal puncture, and hence ice catheter guidance is very useful. What about this? Now on this side, we are moving and moving. Are we on the LAO view? Are we across? Have we, punctured the interatrial septum? And with ice, you will see that this patient has a very redundant interatrial septum. It stretches all the way almost to where the left atrial appendage would be. Under fluoroscopy, I will not be able to appreciate this variation in anatomy. I'll be hesitant to advance the catheter further. I'm afraid I might be puncturing in an unsafe spot. And hence, with this, I'm clear. I know that I'm still tenting at the interatrial septum, and confidently I puncture the interatrial septum at this spot to gain access. Now, for right-sided ablation, let me show you this. This is a patient who needs a CTI ablation, and this is an open irrigated catheter, right, ablating along the cavo tricuspid isthmus. Let me just orientate you. This is an ice image. This is the tricuspid annulus and the leaflet. This is the RV, and this is the CTI, the ventricular end, and this is the IVC end. And you will see that ablation along the ventricular end of the CTI was effective, or at least we delivered RF energy to the area, because This area turns echogenic, turns white, means there's edema, and we are delivering energy and causing ablation damage to this site, this area. But there is a little pouch or a little where the catheter can't touch it. So regardless of what you do, you may deliver high power, but when there's no contact between the catheter and the tissue. And hence, with this, as you curve the catheter, a tight curve, and bring it down, it touches this part of the IVC end of the CTI. Now you know that there is adequate tissue tip contact. Delivery of RF energy will cause cell damage, and the resistive heating will result in a CTI ablation, and hence it becomes effective. So clues to help you reduce your reliance on fluoroscopy and to assess adequacy of tip tissue interface. Now for AFib ablation, I can't go without telling you about AFib ablation. The eyes is useful. You could look at the LA appendage, right? This is the mitral valve. Quickly, you can look at and ascertain where is the LSPV and the LIPV, and this is the interatrial septum. I like to puncture the interatrial septum when I see the left-sided veins in this view, because it becomes coaxial. Once it goes across, you can advance the catheter. It reaches the left-sided pulmonary veins easily in a coaxial manner. You may also look at the RSPV. All right, this is the pulmonary artery, and this is a circular mapping catheter at the os of the RSPV, and this is the RIPV. Likewise, you may move the catheter. You can see the lasso is just touching the os of the RIPV, and you could also assess the tissue interface if needed with your ablation catheter using the ICE images at this various location. Lastly, it's also useful to recognize complications early. Clot and thromboembolic complications is a feared complication in left atrial or left heart work, isn't it? This is one example. You can see clot on the transeptal apparatus before we even puncture the left atrium. And hence, when this was seen, the whole apparatus was withdrawn, cleaned, and the patient was ensured to be adequately anticoagulated before transeptal puncture was done. And also, you may pick up pericardial effusion. Likewise, as a patient who are going in AFib ablation, and you could see a sliver of pericardial effusion that warns you, or what you should look out for, and indeed prepares us for early pericardial tab to relieve this effusion without catastrophic hemodynamic compromise. Hence, ICE is useful for real-time imaging, transeptal punctures, identify ostium of the pulmonary veins in the left atrium. It assesses catheter tip contact and interface. It also helps recognize complications. So with that, I just want to thank you for your attention. That with the technology that we have at this day and age, we could exploit the advantages of each technology to reduce fluoroscopy in 3D SVT ablation, as well as transeptal access for left atrial. Thank you for your attention.
So, Professor Ching, it was really very exciting to hear that beautiful lecture. Really enjoyed it. I must say it's one of the best lectures that I've heard. I have a question. There are 3 catheters that are available for ICE in India. Two are the phased array, one from Siemens, one from Abbott, and one from Boston. So is there a personal preference, or how do you compare these 3 catheters for ICE?
So I've used the Philips as well as the Siemens. Sorry, my apologies. It's a Philips and a GE system that I've used. I have no preference for either, as long as they are phased array, and as long as it provides good imaging of the left atrium, as well as the structures that we want to see. More importantly, the operators needs to learn to maneuver it, and there are ways of maneuvering the eyes to get good imaging, just like doing an echo, a 2D echo, with the transducer on the pectoral, on the chest wall. We need to move the transducer to get good images.
So all that is done is in the right atrium. You just have to clockwise or anti-clockwise turn the catheter to get the images. Is that right? Or superior and inferior? Because it's a stiff catheter.
That is correct. So far, we are able to leave the catheter in the right atrium, and those images were obtained by manipulating the catheter superior to inferior, clock from anterior to posterior. You will be able to get all those images. For the pericardial effusion, it is useful to advance the catheter into the RVOT, which means you can curve the catheter across the tricuspid valve, uncurve it, and you are able to look at the left atrium, almost like a short axis view at the mitral, at the papillary muscles. You could do that, and that shows pericardial effusion very well. I use that image too for left ventricular work, where you need to ablate around the papillary muscles. It gives you very good assessment of the tip tissue interface.
Right. Narasimhan, any comments?
Yeah, a couple of things. We have been using both the catheters. Initially, we have been using the Philips. Now we have been using the Abbott catheters. As Dr. Ching was saying, as long as it's phased array gives a distinct advantage because you have a global view of the whole thing instead of a cross-sectional view. Second thing is, I strongly suggest putting a long sheath up to, because when we try to manipulate the catheter, generally we go from left groin. And if we manipulate more, when you re-sterilize the catheter, the transducer loses all its, the crystals. Of course, probably Dr. Ching may not have this problem. We have this problem. We need to kind of sterilize and reuse this. So I suggest the fellows not to manipulate too much at the level of the iliac vein so that it can be preserved, re-sterilized for more uses. Third, we have been using it for a long time for visualizing both false tendon related VT and intracavitary structure VT, as you mentioned. It's extremely useful because nowadays they do this point and exclusion. You can tag the papillary muscle in a 3D map and then you can navigate to the same area. That's extremely useful in terms of using this. I think there are several uses, and one of the most important thing we have seen is aneurysmal septum, where you may use RF to, rather than puncturing it, when you see it's stenting too much, we go early on to RF to penetrate the septum.
So I would re-emphasize that some people say that let's not wear a lead while doing an ablation. We want to do a zero fluoro. I mean, there is no race. You are not racing to set a record that you want a zero fluoro. Minimal fluoro is good enough, or a low fluoro is good enough. You can create a lot of complication. And this is exactly what Professor Ching had emphasized, that if you get to the idea that, no, I'm not going to step on the pedal, whatever may happen, I have to set a record of zero fluoro, I don't think that makes sense. And but your eye should be on how much radiation. All machines give you, the moment you put a step on your fluoro paddle, they give you how much dose has gone in. And you must be very, very wary of how much fluoro has been used. It's in your interest and in the interest of the patient. So fortunately for us, we have seen a huge fall in the fluoro dose that we used to use some time back and that we use now. And this lecture was very, very important for us to really emphasize such an important aspect of how imaging, how 3D mapping can actually reduce the fluoro dose. Thank you, Professor Ching, for this beautiful lecture.
Thank you.
We move on to Dr. Yash for his talk. And we know Yash has great basic EP knowledge and some very good diagnosis of interpretation of EP tracings and ECG. And there cannot be a better person than Yash to speak on his topic today in this meeting. Over to you, Yash.
Thank you, Balbir, Professor Ching, Narasimhan. So I've put, are my slides visible now?
Yes.
Okay, so I will not waste any time. I have put together 4 cases. If we have time, we discuss all of them. I have not put the multiple choice questions, but I'm going to then leave it to all of your expert moderators to bring out things, pearls from your vast experience. So the first patient is a 62-year-old woman with frequent episodes of tachycardia, not documented on the ECG, but they are taken from the mobile video, which showed rapid neck pulsations. They were actually living far away from any medical help, and could, by the time they would reach medical help, which was a few hours away, the tachycardia would terminate. The echocardiogram was normal. So during the EP study, this is the induction of tachycardia. And as all of you, especially the fellows, would recognize this one, that you can see sinus rhythm, which is normal. There are several premature complexes, some are PACs, some are PVCs, and then you get a regular tachycardia. And the regular tachycardia shows you straight away an R prime in V1, very little ST depression, and the diagnosis most likely in this would be an AV nodal reentry tachycardia. Of course, you cannot always assume that. You need some maneuvers. On the right screen, you can see my arrow, right, Balbir, which I'm moving? Is my arrow seen, which I'm moving on the screen?
Yes, we can see.
Yes. Okay. Okay. So on this half, you can see A on V tachycardia. When we see A on V tachycardia, is where the A is actually at the beginning of the QRS complex. It's most likely AV nodal reentry, but it could also be an atrial tachycardia with a long PR interval. So if you ask me one maneuver, it is the ventricular overdrive pacing, and the ventricular overdrive pacing entrains the tachycardia. Then you look at, as all of you fellows would be knowing, the post-entrainment pattern, which is here V, A, H, and V. And then we measure the VAV, corrected VAV, compared to tachycardia cycle length. We look at how many beats it takes to entrain, and we look at the stimulus to A minus the VA interval. Now, for most of my slides would have this pattern: coronary sinus proximal to distal, then his, and then the RF. So here the RF catheter in the right ventricle is performing the VOP. So AVNRT is not in doubt. The question in this patient is that, interestingly, we usually induce typical AVNRT with atrial extra stimuli. In a minority of patients, you can induce it with ventricular extra stimuli. Now, in this particular patient, repeatedly, we could not induce sustained AVNRT with atrial extra stimuli, which is fine. Sometimes you need isoprenaline to induce, which is fine. So here with atrial extra stimuli, we are inducing 2 AV nodal echoes, which then terminate in the slow pathway. But funnily, even without isoprenaline in this patient, we could repeatedly induce typical AVNRT with ventricular extra stimuli. And this happened at least thrice. Thrice we induced typical AVNRT with ventricular extra stimuli. And every time we use atrial extra stimuli, we could not induce typical AVNRT. So the question is, why? And this was my explanation. Of course, some of our other colleagues contributed in interpreting this. So typically, AVNRT induction with either ventricular extra stimuli or PVCs depends on retrograde block in the slow pathway. That's how it will go up the fast pathway and then re-enter by the slow pathway. Usually, the slow pathway retrogradely is quite robust. Antigradely, you know, the slow pathway has a shorter refractory period, but retrogradely also it has a shorter refractory period, and therefore, to induce typical AVNRT with ventricular extra stimuli, especially a single ventricular extra stimulus, is not common. In this patient, uniquely, it not only could be induced by a ventricular extra stimuli, but could not be induced by atrial extra stimuli, despite having 2 repetitive echoes. So the explanation was that my interpretation or explanation for this was that with atrial extra stimuli, the first A to A was much shorter than it was with a ventricular extra stimulus. And therefore, since the first A to A was shorter, the 2 A to A's were also significantly shorter, as shown here, 570 milliseconds. Whereas with ventricular extra stimuli, the A to A was longer, 690. And this longer A to A allowed the antegrade slope pathway, which was spontaneously blocking, allowed it to adapt and allow tachycardia to sustain. So I'm sure the experts will have some comments on this in the discussion. Case 2, a young man underwent an EP study 6 years ago at another center, continued to have recurrent drug refractory episodes. He was to find a job, get established, then later on get married. The parents really were quite concerned. So here is the first slide. So the sinus rhythm ECG is quite normal. You can see induction of non-sustained tachycardia. And again, you can see induction of non-sustained tachycardia. The first complex shows a right bundle branch block pattern in both instances. There's a little RR variation, which if you look carefully is quite obvious here in the first episode, but then the RR intervals are quite regular in the second episode. Probably this right bundle branch block only for one complex is something like the Ashman's phenomenon for a short long sequence, which then disappears. The differential diagnosis here would be an orthodromic atrioventricular reentry tachycardia, AV nodal reentry tachycardia, and atrial tachycardia. Remember, all of these supraventricular tachycardias can initially have some cycle length wobble. Anyway, if you look at the intracardiac traces here during tachycardia, you find that there is a wave which is within the ST segment. And if you look at the atrial activation in the coronary sinus, the proximal coronary sinus is earlier, but the A wave in the His region is very early. So this straight away tells us that the accessory pathway is not going to be very far from the AV node and the bundle of His. And actually, this was the reason why 6 years ago, after the EP study, an ablation was tried, then alone, because it was probably getting quite close to the bundle of His. Further maneuvers validated that this was AVRT. And this is one maneuver that I want to put for your interpretation. So there is tachycardia going on, and then we are pacing the right ventricle. Can this slide itself tell us that this is AVRT? Because this could also be atypical AVNRT. This could also be atrial tachycardia. Does this surface ECG tell you with confidence that this is AVRT?
So Yash, can you hold on this slide, because let people digest what you're showing. Should I discuss it with you?
Yes,
because
please.
I don't know anything about this patient, so I can discuss. So if we don't have any electrograms, and we know Yash is telling us that it is RV pacing, I don't know whether it is base or apex, but if we see the left half of the tracing, we see a narrow QRS tachycardia. And then we see the pacing spike, say, come after 9 beats.
Somewhere here. Yeah, somewhere here.
Yeah, somewhere here. So this is the first spike that happens. And then let's look at how much time does it take for the fusion to happen. So if it takes long time for the fusion to occur, then it suggests an AV nodal reentrant tachycardia. But if the fusion happens early, first, if we look at these beats, first 4 beats show fusion, and then it is RV pacing. So it happens quite early. So this is suggestive of AVRT rather than AVNRT. AVNRT generally takes at least 9 to 10 beats to get the RV pacing. First 9-10 beats take that much time to fuse, because it takes that time for the ventricle to go back to from the RV apex rather than in AVRT. So Yash, now your explanation on this.
I think progressive fusion, I think in AV and RT, as you said, Balbir, and in fact, you had taught me, or at least sent me this maneuver a few years ago. And since then, I find it quite useful that in AV nodal reentry, the entraining the tachycardia takes time after capturing the ventricle, entraining the tachycardia, which is seen in the intracardiac EGMs. But progressive fusion, you can only get in AVRT. And sometimes actually the pacing can continue as fusion if you're pacing in the same chamber as the accessory pathway. So You can continue a fusion and then you stop pacing and you reinitiate and tachycardia continues. So progressive fusion is itself one of the hallmarks of AVRT.
Very nice. Is it okay if I just give a comment?
Yes, please. You're most welcome.
Yes. Yeah, I think the very nicely and eloquently explained about the progressive fusion. Yeah, I find that in addition to progress or fusion, if I could make out or identify the P waves, that would give me more information. Why do I say that? If there is fusion, which means in the first few beats, obviously on the left side, in the middle of the screen is progressive fusion, and on the right side at the end is total RV pacing, right? So if I'm able to catch the P waves during fusion beat, and the V to A interval is affected with progressive fusion, then that would be diagnostic of AVRT. That confirms the diagnosis. Whereas in AVNRT, you don't get any VA changes till the V is fully captured by the ventricles. Just some thoughts, but beautifully said. Thank you.
Yeah, that's a good point. And actually, I have removed some of the intracardiac EGM slides to make the presentation, within the stipulated time. But here, actually, another thing is that the P wave appears positive in lead 2. It's peaked on the T, and this is the only couple of AVRTs where you can get a positive P wave. We know that in AVRT, conventional teaching for the students is that we get a retrograde P which is inverted. But if the pathway inserts higher up, this may not be true. And there are two situations where the pathway may insert higher up and give a positive P wave in lead 2. And one of these is this pathways on the right side, which are the highest point, that is just superior to the AV node His bundle region, what are called as the anteroseptal pathways. And the others is on the left side, which is really high up, the left anterolateral pathways. So anyway, this pathway was located, as you can see here, in the LAO 40, above the location of the bundle of His. And this you can see in the RAO 30, you can see a CRD2 catheter in the His region, and this is the ablation catheter. And just to show that we discussed with the parents, we spoke to them the chance of AV block, and went ahead and with using low power, we start with low power in these anteroseptal pathways and got good VA block after ablation with an intact AV conduction. So case 3, a young man with several episodes of documented tachycardia in a normal echocardiogram.
Yes, if I may interrupt.
Yes.
Did you ablate this patient during ORT or?
Yes, a very good point, Narsimhan. I should have mentioned that. Good, you brought it up. Yes, we ablated during ORT. And Narsimhan, can you please tell please, because sometimes this point is not, even if this was a manifest pre-excitation, of course, this was a concealed pathway, but even in a manifest pre-excitation, I would always ablate during ORT. Can you, Narsimhan, expound on this for the fellows?
Right. I mean, pardon me if this may sound basic. We have had 2 patients done somewhere for a septal pathway during V-pacing without realizing the patient has developed a AV block. So whenever you have the pure uncorrupted retrograde conduction is seen only during ORT. So especially in septal pathways, the VA block, you can overdrive the tachycardia so that the volume doesn't change during ablation and deliver RF. The fear of the catheter displacement is grossly overstated. So if you entrain the tachycardia during RF delivery, you can maintain a stable contact, and that's the safest way of ablating, especially parahesian pathways.
So Narsimhan, I will add to that even ablating during a manifest excessive pathway during sinus rhythm.
Yeah,
I got one patient where it was a mid-septal pathway and ablated elsewhere. The patient came with a very broad pre-excited ECG, sinus rhythm. And we realized while we were doing the EP, they had already burned his bundle, AV node, and the entire conduction was on the accessory pathway. So if you're ablating during a manifest WPW on an anteroseptal pathway, you may just burn the AV node without doing anything to the accessory pathway and end up with a heart block and accessory pathway conduction alone. And that is even more dangerous.
And the worst you can do is ablate during ventricular pacing, because you'll never know what's happening.
Yes.
So I will move on for the, so there are actually two cases, Balbir, but I thought if I quickly go over this case, and the last case especially I want to show all of you. Or should you want me to skip this case?
No, go ahead.
You please go on. We have time.
Okay. So this is a patient with varying morphologies of tachycardia, and who came with a structurally normal heart. So this was the first one induced by PACs, and it shows, at first you think it's atrial fibrillation, but when you try to look at it more carefully, actually there are well-formed P waves, and it possibly could be an atypical atrial flutter with varying AV conduction. For this, we need more information. So we look at the intracardiacs, and this was the PACs delivered, and that was tachycardia induced. So the PACs from the CS os initiate the tachycardia. If you look at the right atrial activation, and this is with a halo catheter, you can have duodecapolar or halo. So this is a halo catheter. It occupies you see the earliest right atrial activation, which is near the mouth of the CS, and the last right atrial activation somewhere here in the halo 11-12. And that is about 165 milliseconds, which is more than 50% of the tachycardia cycle length. And therefore, this is one of the criteria to call it a macro re-entry circuit. In this case, since it call it atrial flutter. So the activation goes up along the free wall, then along the roof, and then comes down the interatrial septum. So it does look like a clockwise atrial flutter. And then we do the classical maneuver of entrainment. So the pacing is done about 20 milliseconds higher, 10 to 30 milliseconds faster than the tachycardia cycle length. And it shows that in the recovery phase, the post-pacing interval is the same as tachycardia cycle length. Now, sometimes the electrodes that you're pacing, you don't see the A wave properly. So you can take the closest electrodes here with the proximal electrodes. And also you look at the sequence of activation is identical. So it is a CTI dependent clockwise flutter, which was ablated at the medial CTI. CTI can be medial, intermediate, and lateral. And here, please note, there's a clear termination, but importantly, that the tachycardia terminates after the CS electrograms. The tachycardia terminates after the CS electrograms. So clockwise flutter, that's the typical termination. We could still induce another flutter, and this looks like typical flutter. Now you can see in halo a counterclockwise type of activation, and the CS activation is from proximal to distal, looks like clockwise. Again, it was validated by entrainment, and again, this was ablated, slightly away, slightly intermediate, clean termination. But now, look, it terminates between the halo and the CS. So counterclockwise flutter typically terminates before the CS electrograms, and clockwise flutter typically terminates after the CS electrograms. After ablation, don't stop there. As you all know, we will further look for a bidirectional block. This was in a paper by Dr. Saudi and Mohan Nair a few decades ago. So here what we are doing is we are pacing the coronary sinus ostium and delivering RF energy. And what we see is that the halo 1-2 is quite early initially, much earlier than halo 3, 4, 5, 6. And during delivery of RF energy, it moves and becomes the last. So then we know that we have achieved clockwise block. But we also need to validate whether we've got counterclockwise block. So for that, here we are now pacing the same CS os and showing clockwise block. We switch pacing to the halo 1-2 and we show counterclockwise block. So a bidirectional block, if you do have after atrial flutter ablation, and this persists after isoprenaline, then your recurrence rates are going to be very, very low. Now, I know you can do flutter without a halo or a bidirectional duodecapolar, but I think it's a much more elegant way to ablate atrial flutter.
Yash, can we go back to the last slide again? This
Yeah.
one. Yes. So if we look at the final signals in the right panel of the RF catheter, they're very interesting. So when you are pacing the CS 910, you have a bigger potential on the RF, which is a near field potential, followed by a split potential and then a far field potential. But when you pace from the other side, you get the reversal of these two potentials, which is a clear sign of a block.
Yeah, very nice. Nice observation, Balbir. I think there is a lot of things to be, looked for in flutter. So these cases actually were taken from this book, and Balbir, Narasimhan, you all have contributed. A lot of people contributed, and it's available for free access. So this is the last patient I would like to share with you. A learning experience for me, as well as should be for all of the fellows who are attending today. So a young man, many episodes of paroxysmal tachycardia, very frequent and very handicapped, normal heart. And in the last 2 years, he had undergone ablation twice with a diagnosis of typical AV-NRT, continued to have episodes, and was advised ablation this time with a 3D system. So this was his tachycardia. So you can see that the sinus rhythm is normal, and you get a tachycardia which is induced by PACs. You can look at the right side, that's sinus rhythm, normal intervals, a PAC, second PAC, and you get a tachycardia induced. Now, there's a normal QRS duration, 95 milliseconds, although there is a RN lead V1. There's a normal HV interval of 30 milliseconds. Now, we do see sometimes AV nodal reentry tachycardia induced by the 1:2 conduction. So a PAC goes by the fast pathway, and the same one goes by the slow pathway and initiates. And this is seen, I think, in about 2 to 3% of patients, roughly, I'm saying, in AV-NRT. So the first thought was, this is typical AV nodal reentry tachycardia with a little bit of aberrancy giving rise to R wave in V1. So we did some maneuvers, and the first one was a standard one, the VOP during tachycardia. So ventricular overdrive pacing entrains the tachycardia, followed by a long, followed by a VAV response, a PPI minus the tachycardia cycle length, and the stimulus A minus VA, both in the zone for typical AV-NRT. And we gave typical, his refractory PVCs just to rule out a concealed nodoventricular pathway, because this has failed 2 ablations, and it showed there was no advancement of the A wave. However, if we look at this slide, we are pacing in the mid-coronary sinus, atrial pacing, and during atrial pacing, you get 2 complexes which are similar to the tachycardia beats. But if we look at the HV interval of these 2 complexes, it is 30 milliseconds as was during tachycardia. But look at the HV interval when you have the normal QRS, it's 50 milliseconds. And in sinus rhythm also, it was 50 milliseconds. So the HV interval is actually shorter. Something else that you'll notice is the PR intervals are quite different in these 2 beats. It's quite obvious that, so therefore, putting all of these together, these 2 complexes must be PVCs. Otherwise, how do you get different PR intervals? So also note one thing, look at the His electrogram. The amplitude of the His electrogram changes, and sometimes it just changes, the catheter is unstable, but here, it actually changes only during these 2 beats. Otherwise, it's consistently large. So it's not a respiratory change. It's not a catheter movement change, but it's a change because of different direction of activation of the bundle of His. Here, the direction of activation is the normal type, going from AV node, but here it is activation from another focus. So we did atrial overdrive pacing. So that's tachycardia going on. you do atrial overdrive pacing, you stop pacing, tachycardia resumes. And this is the intracardiac showing atrial overdrive, showing atrial pacing. And when you do manage to capture, you get a normal QRS as opposed to the R in V1. So the fact that you produce a normal QRS at faster rates itself should tell you that this is a ventricular tachycardia. And we use this maneuver sometimes in fascicular VT with 1:1 VA conduction. If you want a quick way to know that it's VT, is pace the atrium faster. You pace the atrium faster and you get a narrow QRS, it must be VT. So then this happens spontaneously. Spontaneously, we saw intermittent 2:1 VA block. Now we can have AV and RT with AV blocks. You all have seen very commonly 2:1 AV block, but you can have 2:1 VA conduction also sometimes where the upper common pathway blocks. But if you look what happened with adenosine, we got complete VA block. Tachycardia continues uninterrupted. This would be extremely rare in AV and RT. So putting everything together, the diagnosis now is of a VT, but a VT with a QRS of 95 milliseconds and a normal HV interval, very difficult to digest. So we looked for the site of origin of this VT, and we saw that we got signals which preceded the bundle of his signal with an additional his signal. And this was in the left ventricle, just at the region of what we would call as the upper interventricular septum or the septal fascicle. It probably was going to the his region so early that it would engage the right bundle also so early that it hardly produced any real major right bundle branch block pattern. And therefore gave usually in fascicular VT, the bundle of his is merged with the QRS, or it could be even dissociated from the QRS. Or you could have it just before the QRS with a HV interval of 5 or 10 milliseconds. And a QRS, therefore, a QRS of about 120 to 140. Here you had a QRS of 95 and a normal HV, and that's why one got fooled into thinking this was AV nodal reentry tachycardia. That's my last slide, Balbir. Thank you.
That was a wonderful case, and how one can be fooled by just looking at the signals and the importance of maneuvers is brought out so beautifully in this case. And, very nice observation that his was actually being retrogradely activated through this VT and VT circuit. That's why you had a different polarity of the V on the his. It's a very nice observation. A wonderful case here. Narasimhan, Professor Ching, any comments on this?
Yeah, I think, Yash, we would have seen even in fascicular upper septal pathways being mistaken for AV and RT has repeatedly happened. Multiple attempts, if person has had for AV and RT, just think carefully before you ablate the third time. Look at the diagnosis, EP maneuvers, because all the VOPs, ventricular pacing maneuvers, both of them will be identical. Remember, you saw the example that Dr. Yash showed, the post-PPI interval, VA during pacing and during tachycardia, everything will be very similar to AV and RT. So the two important observations are the HV during tachycardia will be shorter than the HV during sinus rhythm. Second thing is the atrial overdrive will result in capture. So we have had, because ventricular pacing doesn't help you to differentiate this. And it's a very nice case. Thank you, Yash, for bringing it up.
Yes, thank you. It's a very good case. I just one question was during tachycardia, the on V1 it becomes R, the tall R, isn't it?
Yes.
Although the QRS duration, yeah. So a very, very well, astute observation that during tachycardia there are subtle changes to the QRS, although the QRS duration is not as wide as one anticipates in a VT. But we do know that in the interfascicular VT, the interfascicular VT, they can have fairly normal QRS duration. And the A is retrogradely activated. Excellent use of ST observation of changes in QRS, number one. Number two, of observation and changes in HV interval, which I tell my fellows, getting a good H signal and a validated H signal is so important. And thirdly, I want to congratulate you on the use of adenosine, not just pacing maneuvers, observation, but pharmacology. It shows mastery of EP behaviors and maneuvers and understanding of EP mechanisms. Congratulations.
But one caveat to adenosine for fellows to understand is that fascicular VT like that could also terminate with adenosine. So it doesn't really help if it terminates. So one must remember that some atrial tachycardias, fascicular VTs also terminate with adenosine. So
in fact, Balbir, I would go so far as to say that more than 50% of atrial tachycardias terminate with adenosine of the in normal hearts. If you look at perinodal tachycardias, all of them terminate with adenosine.
Right. Thank you, Yash. And please stay on, because we are just going to revise some of the slides that I'm going to show you of what we have learned. So there'll be some polling questions so that I understand that whether people have been sleeping through these sessions or there is something we help them. So this is a maneuver, which is an SVT, and SVT is going on, and some maneuver has been done, and all the intervals are mentioned here. I will hold on to this slide, and we will give 15 seconds to digest what is there. I will come back once I put the polling question. So everything is marked here. The intervals are marked. Some maneuver has been done. His has been marked. CS catheter has been marked. And some maneuver has been done. So what does this maneuver tell us? What has happened to this tachycardia? So I can tell you this is an SVT going on. This is long RP tachycardia. A maneuver has been done to try to distinguish what form of tachycardia this is. And I will put the polling question after 30 seconds. So we can put the polling question now.
Yeah. So I'll just give them a small instruction. So the polling is for delegates who have joined on the webinar link. So when you just go to the window below the questions, you will see a poll button. You can click on that and you'll see the questions one after the other. We are activating the first poll question now, and it will be there for 15 seconds. Once we receive all the results, sir, we will just intimate it to you, and then you can go to the next question. Delegates, you can please activate the poll and check.
So the poll question is, this maneuver suggests that this is A, an accessory pathway conduction, B, it is an OV nodal conduction, and C, it is not diagnostic, we have to do something more. So we go back to the ECG. A, it is an accessory pathway, B, it is AV nodal, C, you can't make out what it is.
Delegates, we're just stopping the polling for the first question. So the answers are in. Option A is 50%, option B is 33%, and option 3 is 17%.
Okay, so it's quite a split. Yash, you want to take this?
Yeah, Balbir. So you have shown the classical administration of a His refractory right ventricular apical PVC. And we always look for advancement, but this is a long RP tachycardia with quite a broad inverted P wave in lead 2. So most likely we are dealing with either in PGRT or atrial tachycardia or atypical AVNRT. These are the three classical differential diagnoses. Now, here instead of advancement, you are getting a delay of the next A. And when you delay, and obviously you have then reset the tachycardia, it can be nothing else but an accessory pathway. So if you advance the atrial activation by His refractory PVC, then it tells you there's a pathway, but it may be a bystander pathway. So you have to look for reset. But if you delay the atrial activation by a His refractory PVC, then it straight away tells you two things. One, there is an accessory pathway, and two, that accessory pathway is part of this tachycardia. So this is PGRT for me.
Right. Thank you, Yash. So whenever we give a His refractory PVC, there can be four things that can happen. A, the A wave may be advanced. B, A wave may be delayed. And C, it may terminate. And D, there may be no change. So in the first three examples of a advancement, delay, or termination, it is highly likely that is an accessory pathway. But if there is no change, it could be AVNRT, it could be an accessory pathway. So it is very common mistake that people give a His refractory PVC and say there is no change, so it has to be an AVNRT, which is not correct, which is not always correct. And one must understand that these are the four things that can happen with a His bundle refractory PVC. Professor Ching or Narasimhan, you want to add anything to this?
Yeah, this is a very, very important slide, because even while mapping, this has a lot of information. If you understand it's a decremental pathway, you may not have a fused VA at the site of successful ablation. So you'll have the shortest VA there with a little bit of a delay. You may not have completely a fused VA. So this has a lot of implications, not only in terms of diagnosis, but also in terms of mapping and ablation.
Right.
Very well explained. One of the reasons why His refractory PVC does nothing to the A, and it might be an accessory pathway as explained, is because where you paste the ventricle may be far from the site of accessory pathway. The nearer you are to the site of accessory pathway when you do the PVC, the greater the chance of affecting or resetting the tachycardia. So this is something that the fellows need to remember. So pasting at different sites of the ventricle may help tease out this effect of the site and distance of accessory pathway from the site of pacing. Well said, thank you.
Balbir, if I may just add one corollary to this, an exact opposite situation is in antidromic tachycardias by a Maheim pathway. Instead of a PVC, if you give a late PAC and it delays the next QRS, it's the same logic for as you showed here.
Right, perfect. We go on to the next maneuver. So this is a maneuver of ventricle pacing. And there are 3 beats. All 3 are paced. What I want to understand from you is first look at this tracing. I have not put the intervals. I will do that when we get the poll question, but it is quite clear. And we don't need, when we see this on the screen while we are doing the case, we don't need to measure. We know what's happening. So there is something happening. So there are 3 beats. The first is narrow, then there are 2 broad beats, and this is a pacing maneuver. So the question here is, this maneuver suggests it rules out, there is no septal accessory pathway, absence of any accessory pathway, presence of septal accessory pathway, or presence of any accessory pathway. So what is correct in this? We go back to the slide. So can we poll the question?
Yes, sir, we are making the poll active.
So Hiroshi had taken a great talk on Parisian pacing. This is something which we can see from here. So this is the clue, and let's look at the answer. So is there no accessory pathway? What does it rule out, or what does it indicate?
So please allow another 15 seconds for the polling.
Okay. No problem.
So the poll results are again mixed here as well. Option 1 is 52%. Option 2 is around 6%. Option 3 is 28, and option 4 is 16.
Okay, so let's look at the same slide. So we have the narrow QRS and the broad QRS. So this is a maneuver of para-Hessian pacing. So if we look at the SA interval with the His capture, you see the SA interval is short. With the RV capture, the SA interval becomes longer. The His is not clearly seen in this maneuver here because we're using the His capture to pace. But the sequence of activation remains the same. So it just rules out a septal accessory pathway, but it does not rule out an accessory pathway which could be right lateral or a left lateral because we are not close to the pathway. This patient may have both AV conduction and a left lateral accessory pathway or a right lateral accessory pathway. It just tells you a differential diagnosis between a septal accessory pathway and a retrograde AV nodal conduction. And this suggests that this patient does not have a septal accessory pathway, which is the vast majority, 53% did answer this question. Yash?
Yeah, Balbir. So, para-His pacing, and this was, even in the book, Professor Wellens has pointed out many possibilities with para-His pacing. So for the fellows, para-His pacing, really first you need to know whether it's capturing properly. But from my take on para-His pacing is what you see is present. It doesn't exclude anything. So here, as Balbir clearly showed, sequence same, duration of activation longer. So AV node is present. So there is a retrograde AV nodal conduction. I can say that from this. I cannot exclude anything from a para-His pacing. That is my take on para-His pacing.
Right.
And the important then, if I ablate this pathway, suppose there would be a pathway in a particular patient. If I know that there is retrograde AV nodal conduction, then I expect VA conduction to be present after ablation.
Right. So the most utility
that is also one of the things that
the most utility of this procedure is when you ablate a septal accessory pathway and the patient has both conduction on the septal accessory pathway and the AV node. And now after the ablation, you are confused whether the conduction is still intact or not. Para-Hessian is very useful at that stage. Once you have done the ablation and now you want to be sure that you have done a good job. You may not induce the tachycardia with a half-done job, but then it becomes quite useful at that stage to use this maneuver. We go on to the last slide. I will skip this. I will go to this. So this is very important slide because this happens in the lab quite often. So this is a patient who had a slow pathway ablation for AVNRT, following which induction couldn't happen, but then isoprene was given and an SVT was induced. So this happens quite often that we have now an SVT on isoprene after slow pathway ablation, and we get an SVT. Now this is the SVT happening. Now, sometimes what you have to distinguish is a junctional tachycardia for an AVNRD, because if you have induced a junctional tachycardia with isoprene on, you may just keep ablating and the tachycardia doesn't disappear. And this is some maneuvers have to be done at this stage. This is an atrial overdrive maneuver happening in this patient. Tells you what? What does it tell you? Can we have the polling question? So this is the last of the day because we're short of time. But this is an important maneuver which I thought must be discussed.
So this is question number 4.
Yeah, question number 4. Yes.
Okay, sir. Okay, so we're just making it plain. The polling results are still coming. It will just wait for another 3-4 seconds.
Fine, no problems.
Yeah. So option A is 64%, option B is 18%, and option 3 is also 18%.
So this is a very important maneuver, which is an atrial overdrive. So you can do 2 maneuvers at this stage to distinguish between junctional tachycardia. And Pristowski described these maneuvers, which are very important because isoprene can induce junctional tachycardia and you may keep ablating an AVNRD. So this maneuver suggests an AVNRD actually, that when you overdrive the atria with a junctional tachycardia, you get a response like you get a VAAV response for an atrial tachycardia on ventricular pacing. You get a similar response with this. Here you see that with the atrial overdrive pacing, it does nothing to the tachycardia. Tachycardia is going on, which suggests that this is re-entry which is happening. So you could do an atrial overdrive or an atrial extra stimulus. So this suggests that you must ablate more in this patient to get rid of this AVNRD. And you will get this, fellows must understand that you will get many such patients where you try to induce on aspirin and you get a junctional tachycardia. So with this, we end today's session. We just right on time. And I really thank Yash for and Professor Ching for brilliant lectures. We really enjoyed them. And any comments from both of you? And I give it over to Narasimhan to introduce the 7th session.
Again, thank you, Dr. Ching, as well as Yash, for a wonderful presentation. The content was extremely good and I think very, very relevant to practice of EP day to day. How to minimize complications, how to be efficient in the lab, so on and so forth. The next session is going to be on the 11th, that is Saturday, next Saturday. And we'll be first having a recap of the previous modules. And then we'll have 6 teaching cases with MCQ format and an interactive discussion. And then if there are any questions, either in this module or the previous module, please post them. We'll kind of wrap up those queries and then we'll move on to the VT module after 2 months. That will be in short the agenda for the 7th module. And I would like to end and thank Abbott for making this possible. Thank all the faculty and hand over this to Rahul. Balbir?
Yeah. So
Rahul
is not joined.
on the
So
line. So thanks once again, sir. I mean, for all of us for joining, and then we'll meet in the last and the next session on 11 June. Thanks.
so look forward to joining on 11. Thank you, Professor Ching, and thank you, Yash, once again.
Thank you.
Thank you.